Hi, everyone. Thank you so much for coming to today's CoLab Presents. We have a really great presentation from a few of the CoLab team members about the most recent safe supply project that they're working on. So I'm looking forward to this presentation. I'm going to pass it to Dr. Bernie Polly to introduce the rest of the team. Thanks.
Thanks, Brittany. I have had the pleasure of working with some amazing team members on developing this presentation. And first of all, Nancy Henderson, who has joined us as a PhD student and a research assistant. Phoenix Beck McGreevy, who's also a peer research associate with Safer Supply Projects, and Abby Hutchinson, who's a research assistant with us as well. And all of us are at the Canadian Institute for Substance Use Research at UVic. And if you can go to the next slide. The University of Victoria stands on the traditional territories of the Lekwungen peoples, the Songhees and Esquimalt First Nation, and we respectfully acknowledge that we are located there and recognize the Lekwungen and Wasanic peoples whose historical relationships with the land continue today. We humbly acknowledge that we're uninvited settlers on these lands and recognize the disproportionate impact of the toxic drug crisis on First Nations, Indigenous, and Métis people as a result of historical and contemporary impacts of colonization, and particularly the deeply racist roots of drug policy and prohibition in this country. Next slide. We want to honor our team members, family, and friends who we've lost to the drug crisis, the toxic drug crisis in this country. In our presentation today, we're bringing together several pieces of work. One is a scoping review of the state of evidence for prescriber and non-prescriber-based safer supply, work that we've been doing to develop a range of models of safer supply, recognizing not one size fits all, and to look at next steps in our work, particularly how we're working with Bohdan Nosek and his team to model the impact of different approaches to safer supply. Next slide. When we talk about the evidence of need for safer supply, and I think, Phoenix, if we can go back one, that would be great, to show. It's just a slide of that's not there. Okay, I'll tell you what. Oh, there it is. Phoenix, you're amazing. Phoenix did an incredible job of editing and putting the slides together for us, so they look absolutely beautiful. But when we think about the evidence for an intervention, Lancaster and Rhodes, who are theorists and researchers in the area of substance use and harm reduction for a long time, highlight the difference between evidence of the need for an intervention and evidence that is created when you evaluate an intervention. So if you just kind of keep that in mind, we are 8 years into a toxic drug emergency, declared public health emergency since 2016. And you can see here, this is the most recent data from the BC coroner, which highlights the desperate and urgent need for interventions and the importance of calling for safer supply. And that's what our focus is on today, both in terms of evidence and possible models. Next slide. I just want to highlight, we have heard a lot of conversation about safer supply as being a problem versus safer supply as being a response. And I think we're all familiar with this, but it's the unregulated drug supply and the high concentrations of fentanyl that are responsible for overdose deaths. And this is happening in a context of prohibition. And I want to highlight that these harms of overdose deaths are increased when there's insufficient housing, poverty and homelessness, history of colonization, and of course the criminalization that comes with prohibition. So important to recognize that unregulated safe supply or an unregulated drug supply will impact anyone who accesses it with the potential for a non-fatal or fatal overdose. But that some populations are disproportionately impacted. And we can go to the next slide. And I'm going to turn it over to Nancy to talk about the scoping review that she did.
Hi, everyone. So I'm just going to run through the scoping review protocol quickly. So the first search of the literature was completed in October 2022, and then it was updated in July 2023, and then again just last week on January 21st, 2024 to capture the most recent additions. The objective of this scoping review is to understand the facilitators, barriers, and outcomes of prescribed and non-prescribed models of safer supply. The inclusion criteria for this search included prescribed safe or safer supply or prescribed safer opioid supply, risk mitigation guidance or prescribing, immediate release opioid and stimulant replacement, compassion clubs and buyers clubs, Indigenous-led safer supply, or substitution or replacement programs. The exclusion criteria were programs that focus on harm reduction, but not in relation to drug replacement, programs that use long-acting or extended release medications exclusively, and programs that use witness dosing exclusively. So our goal was to capture all peer-reviewed and journal articles on the topic, and there were no limits to the publication year. Next slide, please. So I predominantly used Medline, CINAHL, and PsycInfo databases, as well as Google Scholar. Citation searches or reference list reviews were completed. However, the search captured what we needed. The search identified 342 potential articles, and after accounting for the 136 duplicates, we screened 206 titles and abstracts. During this screening, 116 articles were removed, leaving us with 90 articles to screen the full text. During the full text screening stage, 47 articles were removed, predominantly because they were non-empirical methods, but also sometimes because they were the wrong intervention or only mentioned safer supply as a recommendation. With that, we were left with 43 peer-reviewed articles to review. And I think it's really, it surprises me that we are already up to 43 peer-reviewed articles, and I think it's really amazing. So in addition to these 43 articles, on the next slide, these represent some of the program evaluation reports that are not included in the scoping review, but that definitely add to the evidence. It was through this search of the gray literature that we also found one report by Dulf about the Compassion Club model, and there are so far no peer-reviewed articles on this topic. Next slide. So these next 3 slides give an overview of the 43 articles included in this scoping review. Starting with study design, there are 23 studies using qualitative methods, 18 using quantitative methods, and 2 environmental scans. For the qualitative articles, 13 are implementation papers looking at barriers, facilitators, and/or outcomes of safer supply. And some of the others included articles about drug use practices and preferences, case reports, and then there were 3 papers tackling more commonly heard critiques of safer supply around diversion and youth. For the quantitative articles, 5 of the articles are population level, cohort, or observational studies. You could go back to the previous slide still. Then the remaining 13 quantitative, 5 of the articles are population level, and they're either cohort or observational studies. The remaining 13 quantitative papers included things such as studies about drug choice and preferences. Did I already say all this part? Sorry. And 2 slides that look the 13 quant articles include things such as 4 studies about drug choice preferences, 2 studies that look at opioid agonist therapy or injectable opioid agonist therapy using risk mitigation guidance, and 2 based on chart reviews, and 3 that were based on public opinion or awareness of safer supply. Safer supply research has only appeared in journals since 2020, so 43 articles is pretty great. And the 6 papers from 2020 and 2021 were all qualitative papers from Vancouver. And it makes sense that there weren't very many, as safer supply prescribing was just starting to gain traction. And to note is the last 5 out of the last 6 papers have used quantitative methods. When we look at where these studies took place, we can see that 2 were national environmental scans and 5 involved multiple provinces in their analysis. So for example, the public opinion article, one of them covered Alberta and Saskatchewan, and one evaluation article on the MySafe project covered cities in BC, Ontario, and Nova Scotia. While the majority of papers are still coming out of BC as a province or large urban centers such as Vancouver or Victoria, results from Ontario have begun to appear as well, with the majority coming from large urban cities such as Toronto, Ottawa, or London. The size, again, the focus is on large urban centers, and which also makes sense because that's where the majority of safer supply programs exist, especially in Ontario. And while some of the research includes various sizes of urban centers, there have to date not been any studies based exclusively on medium or small urban centers, with the exception of the one study out of a rural BC community. So who participated in these studies? Most studies included the voice of or data about people who use drugs. There are 12 studies that included the voices or ideas from the perspective of prescribers or program leaders and healthcare planners. There's an overlap in numbers because some of the studies included people from both groups. And then there are 2 studies analyzing public opinion of safer supply as a facilitator. The participants of these studies have been recruited from various locations, with 15 coming from safer supply specific locations, 10 coming from safer supply that has been integrated with other programs such as IOT or OAT or shelters or COVID hotels, and 18 coming from a variety of community locations such as harm reduction sites, public databases, and places people use drugs frequent. So I'm going to, in the next 2 slides, break down the literature into 2 categories. First, implementation, and then outcomes. So starting with implementation on a program and systems level, 38 out of the 43 papers provided information about barriers and facilitators of safer supply. And to note, these barriers and facilitators are real or perceived, as some of the studies were before implementation. So the first theme is relational. Facilitators included low barrier, flexible, safer supply models, trust, including through having existing relationships with prescribers and teams, listening to people who use drugs, and eliminating stigma and discrimination, and ensuring equitable access to a safer supply. The next theme is health and healthcare. Barriers included frequent clinic check-ins and pharmacy visits, overall program structure, over-medicalization, and COVID restrictions, including reduced services. Program structure was for some people a barrier and also sometimes a facilitator. Facilitators included the creation of guidelines and creating a standard of practice where safer supply programming or prescribing is just another tool for prescribers to use. For drugs and drug use, barriers included lack of drug choice, dose, and route, lack of carries, and the requirement for witnessed doses. A history of prohibition and restrictive policies were also barriers. Facilitators included adopting decriminalization, legalization, and regulation of all drugs, as well as COVID creating tensions and pathways for new guidelines to emerge. Under social and political, the amount of prescriber fear or comfort was seen as a barrier or facilitator to prescribing. The precarity of harm reduction, political will, and public opinion were seen as either barriers or facilitators of safer supply. Lack of evidence and lack of training and education for prescribers was seen as a barrier. Having access to a community of practice, support from professional colleges, and adequate funding were seen as facilitators of safer supply. Moving on to the outcomes, 32 of the 43 articles spoke about outcomes of safer supply, and they were overall positive. Under the theme of relational, experiencing agency and autonomy, feeling understood and hopeful, and regaining trust in healthcare were all positive outcomes experienced by participants of safer supply. In addition, under the relational category, we saw an overall increase in engagement in services, including primary care, and increased retention rates compared to other programming. For the theme of health and healthcare, the outcomes to note are chronic disease management and pain management, and overall improvements include health, including physical and mental well-being. There were 2 population-level cohort studies that reported on hospital outcomes, and they had some conflicting results, with one saying that hospital emergency department and admissions decreased with access to safer supply, leading to decreased costs associated with healthcare, and the other saying that hospital was increased due to opioid-related visits. Under the theme of drugs and drug use, having access to a known and reliable supply, decreased cravings and withdrawals, decreased drug use, gaining a sense of safety, and decreased overdoses were all positive outcomes of safer supply. Social and political is the final theme. Positive outcomes included decreased hustling and participation in criminalized activities, increased access to money and food, improved quality of life and social well-being, stabilized housing, and overall community benefits, such as increased numbers of programs available to people, increased enrollment in programs, COVID isolation adherence, diversion as both positive and negative, and that although safer supply as originally intended, that was first put out by CoP, some reported that what we have is better than nothing. So to conclude this scoping review portion of this presentation, there are currently 43 peer-reviewed articles linked to safer supply. All of these studies are about prescribed safer supply, and all but one of the outcome studies speak to the positive uptake and outcomes of safer supply prescribing. Although not surprising within the context of prohibition and oppressive drug policies, no peer-reviewed articles on non-prescribed safer supply appeared in our search. There are multiple recommendations from these studies. However, the one that stands out the most was the request for a range of models that include both prescribed and non-prescribed safer supply. And I'm now going to pass this back to Bernie to lead us into the second part of our presentation.
Thanks, Nancy. In addition to this scoping review that Nancy presented, we have been working with Dr. Bohdan Nosek and his team at SFU and the Center for Advancing Health Outcomes on a CIHR-funded study to look at integrating the perspectives of people who use drugs and healthcare providers in modeling the value and long-term impact of current and potential future scenarios for both regulated and unregulated models of safer supply. And I think just to kind of pull out 2 points, one is that we need access to safer supply beyond people with opioid use disorder. That's one group, but there are actually multiple groups across the population that might be accessing the current unregulated and toxic drug market. So, you know, that's a really clear indication of need. And there's also a lot of the prescriber models, as Nancy referred to, face barriers in terms of scale up. And we don't have necessarily the number of programs to meet the need and to address some of the barriers to access. So positive outcomes of those programs, but recognizing, given the scope of the public health urgency that we need more. So this work is really focused on developing. Our part of the work has actually been to develop the scenarios. Next slide. So as I mentioned, we in this work began with the reality of what we had, which is the provincial prescribed safer supply initiatives. And I really just want to highlight that these are provincial initiatives. Within this, there may be multiple different ways that programs are implemented and developed. And we have the original risk mitigation guidance, which was introduced during COVID and then updated in January of 2022. And in July of 2021, we have the PSS, or Prescribed Safer Supply Policy Direction, from the British Columbia Ministry of Health, and which since that time in 22 and 23, a number of fentanyl-specific protocols have been developed further. So remembering these are initiatives that kind of set the baseline or the stage against which other models what other models might look like. And I'm going to turn it over to Abby and Phoenix to share with us the work we've been doing on developing the models. That's a lie. I just lied to you. I'm actually going to talk to you about how we develop the models. We develop the models by doing a secondary analysis of data from 3 different studies. And I just want to acknowledge the amazing collaboration that we had. There was a study that we did originally, concept mapping study that looked at, created a model for what effective supply looks like from the perspectives of people who use drugs, and we can give you that reference. And then the BC Patterns and Preferences study that was led by Jane Buxton and Jessica Xavier, and Phoenix was a part of that study as well. They shared their data with us for secondary analysis. And then thirdly, the Imagine Safer Supply study by the Canadian Drug Policy Coalition, in which Phoenix participated. We also had an agreement with them, and they generously shared their data for this. And we had ethical approval to do all of that through UVic and UBC. So now I'll turn it to Abby and Phoenix. Thanks.
Hi, so I'm going to start by talking just about some of the models that we have developed. You can see them here on the screen. These models were developed through secondary data analysis. All of these models outside of the event-based distribution are also being evaluated through a survey with people who use drugs from across the province. The risk mitigation guidelines is considered to sort of be the baseline for what currently exists, as Bernie mentioned, to which these models can be compared to. What we are presenting here with these models is our future scenarios, or what could be possible based on the preferences, ideas, and concepts in the data sets. Next slide, please. I'll speak first to the prescriber-based models, and then I'll hand it over to Phoenix. For all of these models, medications, all the prescriber models, all the medications offered reflect what is currently available in BC, which is outlined with the risk mitigation guidelines. The first model, virtual prescribing, is where someone can access a prescriber over the phone or Zoom. A version of this model with specific recommendation from the First Nations Health Authority is an Indigenous-led virtual prescribing model with majority Indigenous healthcare providers and prescribers with holistic care and connection to culture. The next model, patient-guided prescribing through an individual prescriber. In this scenario, the individual accessing prescribed safe supply has more agency and decision-making power. Through an individual prescriber, the patient can guide conversations about their personal preference for medication type and dose. And the final prescribing model is similar to the previous model in that the patient has more agency and decision-making power, but they're also offered connection to a team for wraparound services. If this is something they would like to access, they would be offered connection to additional health and social supports, such as mental and physical health supports, peer support, housing, and food security supports. Next slide, please. So the quote on the right side of the screen kind of illustrates the team-based prescribing, making sure that it is more holistic so that people do have supports if they need those supports. whether it's wound care, health advice, or referral for health or sexual health, or someone there to educate. It needs to be holistic, where it's not mandatory, but it's available for whoever wants it. Throughout the data analysis, we saw that some individuals did have preference for a prescribed-based model. In some cases, this was simply because this was a model that worked best for them. In other cases, this was because it was hard to conceptualize models outside of prescriber-based within the context of continued criminalization of drugs and drug use. What was more common within the data was that people had negative and traumatic experiences within medical systems. People described experiencing stigma, discrimination, and medical surveillance. Additionally, in many cases, the medications currently available did not meet the needs of the individuals. So we can sort of see that outlined here with the other quote on the left. There's so much stigma already in healthcare systems, you know, with people that are addicted trying to get help. Most of them have already been traumatized in the healthcare system. So I'm going to hand it over to Phoenix now to talk about the non-prescription models.
So frequently what we saw in the data was a desire for more of a community regulated sort of model. So the Buyers Club and Compassion Club are sort of similar, although Buyers Club is sort of more of like a bulk purchase, low interaction sort of model where you put in a bunch of money and buy in bulk, and it is either delivered via the mail or what some other sort of courier or delivery service. Whereas a Compassion Club is more of like a storefront or something where you could buy smaller amounts. The main focus of both of these is that it's run by the community, for the community. There's no gatekeeping or healthcare stigma, things like that. Dolph is a really good example of a Compassion Club sort of model. These are less judgmental, a lot less surveillance, and more client or patient centered, or like. And the other thing that's really great about these, that's also touches on something we're going to cover in the next couple slides, is the reliability. You know that they're going to be there, you know what the stuff is, you know what the price is going to be, and there's no surprises, there's no standing out in the fucking rain for an hour waiting for the guy. Here are, oops, sorry, some quote about some of the ideas that folks had. And Abby mentioned this a little bit, but definitely it's really hard to get folks to imagine something that doesn't exist, to go outside of what they think is available and what they think is possible. A lot of times when we were talking to people in some of the studies that I was working on, they would say, oh, it would be cool if we could do this, but we can't. And so really trying to get folks to open up that really creative, imaginative side and see what they wanted was quite difficult. So some folks were thinking about like a community center, a building where it had a chill out room, a built-in studio, people can do music, all that sort of thing, like creative and community building sort of outlets. Okay. So the other non-prescription model that I'm going to touch on, sorry, 1 second. Pardon me, is a event space distribution and a dispensary. So an event space distribution is either something like a cafe, coffee shop, a nightclub, things like that. So you can go to a bar or a dance club and buy liquor. So it would be basically like that. It would be very hands-off, regulated by age of the participation in the event space. The sorts of substances that would be available there would be dependent on what would be available commercially. The dispensary is also sort of very similar to the Compassion Club, but it's run for profit. So basically that's the sort of downside of these two, is that they would be run for profit, either by the government or by a corporation or a group of people. So not as much about community building, but about money. Alrighty. So one of the things that came through really clearly from a few participants was just like, the liquor store is such a perfect example. Like, just go in, you buy the thing, it's there, it's open, you know what's in it. Like there's none of this hand holding. It should be like alcohol. You should go in, see the cashier, grab your shit, and go. So these two quotes really sort of exemplify what people want to see in like a cafe, like a more social sort of setting, like a cafe or a nightclub, versus you know, a store, like a retail store. I am going to pass it back to Abby.
Thanks, Phoenix. For next steps, we are currently conducting a survey evaluating these different models. The survey was developed with feedback from local Victoria drug user organization Solid and the Advocates for Drug War Survivors. The surveys are being conducted with people who use drugs in different areas across the province. The surveys evaluate individual preferences for the different models. For example, if people can see themselves accessing the different models, if they think it would be easy or difficult to continue to access each model, and if their use of the illicit supply would change. We hope to conduct 35 surveys total. So if you know anyone who is 19 or older living in BC and accessing the illicit market, feel free to tell them to get in touch. Our emails are on the next slide. Yeah, so that kind of concludes our presentation. Phoenix, if you would advance to the last slide. Yeah, our email addresses are there. Yeah, thanks for listening. I think we do have some time for questions.
Thanks, everybody. What a great presentation. I really appreciate it. And honestly, I learned a lot. I think Bernie made a joke that I wouldn't learn much from this, but I did. And I'm going to share this with a lot of people. So really appreciate it. I'm going to turn off the recording and then we can have an open discussion.